Hello, everyone. This is Dr. Mickey recording a lecture on Chapter 36, which covers the drugs and medications for the TB, tuberculosis, fungal infections, protozoal, and helminthic infections. So what is TB? Tuberculosis or tubercular infection, which is an infectious disease caused by the bacteria called Mycobacterium tuberculosis. And this bacteria, it can target any tissue in the body, but involves mostly the lungs and can also occur in any other parts of the body. So what are the tissues that are mostly affected by this disease? And just to note that this is a highly contagious disease, and approximately there are more than 2 billion people affected by worldwide, globally affected or infected with TB. So the favorable environments, in other words, what are the most affected tissues tissues are most affected by this disease. First, the upper lobes of the lungs, kidneys, epiphyses of the bone, which is the end parts of the lung bones, and the cerebral cortex and the adrenal glands. So the TB is still to be considered as the world's second most common cause of death in terms of prevalence from infectious diseases, and that's after or this disease TB in terms of the second most common cause of death after the HIV/AIDS. So talking about worldwide infection, we said more than 2 billion people are affected by this disease worldwide. In the United States, persons at risk include the homeless, people residents in the inner city neighborhoods, the foreign-born persons and older adults, people who resides or is institutionalized in institutions like long-term facilities and rehabs and prisons and incarcerated, units. IV injecting drug abusers or users, and poor access to healthcare or difficult access to healthcare. The resurgence of this disease has dropped in the 1940s and 1950s, and in the US, the higher prevalence in areas with large population of Native Americans, healthcare workers are considered to be at high risk as well. So the resurgence of this disease, the high rates of TB with HIV infection. So there is an increased rate of HIV infection. With the HIV infection, we have seen more of TB cases because of the HIV. Since the HIV infected people start to rise. So the multi-drug resistant strains also of the tuberculosis or Mycobacterium tuberculosis, that's another reason for the resurgence. So it's two things. It's the high rates of, so even though the resurgence, as we said previously, that it has dropped in 1940s and 1950s, but the prevalence, I'm sorry, and then the resurgence, it's higher because of high rates of TB with HIV infection. Second, because of the multi-drug resistant strains of the bacteria of the Mycobacterium tuberculosis. We have seen more strains of this multi-drug resistant bacteria. So the resistance results from the several problems including the incorrect prescribing of the medications or treatment, the lack of public health case management, and because of the patient non-adherence to the prescribed regimen. Now, the spread of this disease, it's known to be via airborne droplets. When an infected person cough, speak, sneeze. So the spread, not by hands or objects, or brief exposure, rarely would cause any infection, but most would be through the as a droplet airborne droplet precaution supposed to be instituted because the disease will spread through the coughs as you speak, very close distance to the infected people, sneezing, and so and the like. So the transmission requires close, frequent, and prolonged exposure. So there is a latent TB organisms that would persist for years. But the reasons for the reactivation of this disease are not well understood. That latent TB that will persist for years and that reopens and reactivates. So the reasons for this reactivation are not well understood. Now, the TB infection in a person who doesn't have the active TB is referred to as a latent TB infection. That's like, for example, have been infected and then the disease will be dormant, inactive, and then during this period of time, this period, the individual will be, or the person has been infected in the past will have what is called the latent TB infection. An estimation of more than 15 million individual affected in the U.S. Have a latent TB infection. The TB replicates slowly and spreads via the lymphatic system. So if the cellular immune system is activated, then the tissue granulomas would form. So the patient will live with granuloma in the lungs. Tissue granuloma would form, and the bacteria will be contained, kind of dormant and contained, preventing the replication and spread of the disease. There is a classification of the TB from like a zero, it's like a scale of 0 to 5. Like 5 is TB suspect, 4 TB but no clinically active, 3 TB clinically active, 2 latent TB infection, no disease, 1 is TB exposure, no infection, 0 would be like no TB exposure. And this figure explains or illustrates and describes the cycle of this infectious disease in terms of how the infected individual would infect other healthy individuals. The physiological and pathological changes in the lungs that will take place during this infection. This slide explains some of the cultural and ethnic health disparities as it pertains and contingent with consistent with this disease. So the slide illustrates this point, which is the cultural and ethnic health disparities. Now, pulmonary TB. So from now, this disease, as we said, it can affect this bacteria, can affect any tissue in the body, but we're going to focus on the pulmonary TB. Even I have seen like cases like certain hospitals of a TB that affected like a surgical post-op or like surgical incision or wound, like hip surgery. I have seen like in all the cases over last few years of a TB infecting the post-op surgical site of the hip, like incision or wound. So surgical wound. So again, from now on, the remaining content for this lecture will be focusing on the TB affecting the lungs, so it's pulmonary TB. The clinical manifestations, so we have early stages that are usually, patients will be like free of, like asymptomatic, no symptoms. So the table here illustrates and includes the signs and symptoms for persons with TB disease. Bad cough that lasts 3 weeks or longer, pain in the chest, coughing, blood or sputum. So this is the hemoptysis, cough tinged with blood or mixed with blood. The weakness or fatigue, very significant symptom of TB disease. Weight loss, another one. Anorexia, no appetite, and chills and fever, and sweat at night. That would be another significant sign or manifestation of the TB disease, pulmonary TB. So people with, or individuals infected with the latent TB, LTBI, they have a positive skin test but are asymptomatic. So they have a PPD test will be positive, but no apparent symptoms available right now at the moment, because the disease is dormant, kind of inactive, but the bacteria is still there. It's had formed this granuloma in the lungs, and it's inactive. At some point, when the immune system becomes compromised, or other factors may play in, like play a role in this disease, then the patient will be symptomatic. So PPD test during the latent LTBI, latent TB, patient will have a positive PPD, but no symptoms, but asymptomatic. These are some of the complications of the TB, miliary TB. So before we get to the complications, we kind of highlighted the most important symptoms, the acute symptoms, the high fever, chills, pleuritic pain, from pleural pain within the lungs, productive cough, and we said it's hemoptysis, tinged like cough, tinged or mixed with blood, fatigue, malaise, generalized weakness, and anorexia, weight loss, night sweats, very significant to the TB symptoms. Next is complications. So the miliary TB, which is a necrotic, this miliary TB in which there is a necrotic complex which will get through the blood vessels with large numbers of organisms invading the bloodstream, and they're spread to all organs. This is in miliary TB. Again, it's a necrotic complex that will erode through the blood vessels with large numbers of the microorganisms invading the bloodstream and are spread to all organs. It can occur as a result of the primary disease or reactivation of latent infection, in which the acute symptoms with this miliary TB, fever, dyspnea, cyanosis, with the acute symptoms. With the chronic symptoms, it will include the systemic manifestations of weight loss, fever, GI disturbance, hepatomegaly, splenomegaly, generalized lymphadenopathy may be present. Pleural effusion caused by bacteria in the pleural space. Inflammatory reaction with pleural exudate of the protein-rich fluid. So there is some exudate that is going to be present in the lungs, and that is called pleural effusion. The empyema, that's the pleural TB that can result from either primary disease or reactivation of latent infection. But obviously, when you say empyema, means pussy drainage. it's infected. There is bacterial infection, and it's a pus drainage. So the empyema means there's a pus around the lungs, and TB pneumonia, large amounts of the bacilli bacteria discharging from the granuloma. Remember that we have pulmonary granuloma that would form after the disease process with TB, and then this large amount of these bacteria, the bacilli bacteria, will be discharged from the granulomas into the lungs or lymph nodes. And which are the clinical symptoms or manifestations are similar to those of bacterial pneumonia. So the skin testing for or diagnostic studies for a TB, before we get into the collaborative or management of patients with TB, just briefly going over the diagnostic testing, and the first test would be the skin test. So which is the immune response demonstrated by the hypersensitivity to the PPD of TB, which is, in other words, is the PPD test, purified protein derivative test, PPD, which is the intradermal administration of the tuberculin test, in which that we are going to wait for 72 to 48 hours, 48 to 72 hours for the induration at the injection site, which will indicate the exposure, negative or positive, to the TB. The sensitivity to the TB will remain for life, and the individual should not be tested again. Or what we can do is that if the patient has a positive, we'll cover most of this content in terms of the PPD test, how many, who should, required to do the test, and who is supposed to do just in the X-ray, and other, like parts of this discussion will be part of the adult health courses. So in which that we administer about or inject 0.1 milliliter of the PPD intradermally on the dorsal surface of the forearm. And usually the test is read by inspection and palpation about 48 to 72 hours later for the presence. After that, we will read it in 48 to 72 hours after the injection. For that, we'll go and check the test and read it for the presence or absence of the induration, raised or redness area, of redness or raised area. So this induration, if that induration area, that's the raised plus the redness around it, if present, it's then it's measured and recorded in milliliters, so millimeters. So it's from 0, 1, 2, or 3 millimeter induration, or we can say no induration, in which 0 induration, no induration. So the numbers, in terms of the numbers, it depends on the immunosuppression or the immune system competency. In other words, that the patients who are immunosuppressed, we anticipate that the immune systems are going to react effectively to the PPD test, and it will be still even exposed to TB, but they are like HIV/AIDS, individuals or people with immune suppression or patients on immunosuppressant drugs in which their immune system is compromised. So we anticipate the reaction will be very weak, in which that the reaction of or response or an induration of 5 or higher will be considered as positive for those people. So again, the response will be decreased, attenuated in immunosuppressed or compromised patients, HIV/AIDS, and patients on the immunosuppressant drugs. So the reaction will be very weak. So 5 millimeters in duration or higher, that will be considered as positive in those patients. However, that patients with the competent immune system and no HIV/AIDS, not not taking or not taking any of the immune suppressant drugs, then we will go with the 10 millimeters or higher to be positive for TB disease in terms of exposure, like positive test. So that's how you read the PPD test, but that's just briefly, and we will cover more about the PPD test and other diagnostic testing in or studies in adult health courses. Chest X-ray, the bacteriologic studies like the AFB test, acid-fast bacillus, in which that you will test for the presence of this microbacteria or this bacteria in the sputum, and the quantiferon TB test, another one. So these are diagnostic testing or studies will be discussed more and more, like in depth and details in adult health courses. Now the management, back to the management of patients with pulmonary TB. So most patients will not be hospitalized. So once the disease is active, patients being diagnosed, confirmed diagnosis with symptoms, then they need that require the treatment. Then patient will be hospitalized, and the in which that we have to institute or begin or put the patient on the airborne droplet precaution, airborne precautions. So the medication or therapy must continue for 6 to 12 months. Patient will be hospitalized, but once patient's diseases became like inactive, in which that patient will be on antibiotics, and then patient will receive the course of this antibiotics prescribed, and then the patient's test, and especially the sputum test, 3 consecutive tests over 3 consecutive days will be negative. That will be patient will be off the isolation. Patient can also, or precaution, the airborne precautions, and patient also will be this can be discharged. So the active disease, in which that the initial phase, so patient will be on the daily therapy for 2 months. The 4 drugs will be prescribed, and we have these drugs are the isoniazid, INH, rifampin or rifadin, pyrazinamide, PZA, and ethambutol. So these are the 4 medications patient will be on these 4 meds for 2 months. So in most circumstances, the treatment regimen for patients with previously untreated TB will consist of the 2-month initial phase with 4 drugs, with these 4 drugs. And the treatment, again, it's very aggressive so we can combat this resistant strain of TB. And that's one of the reasons we combine all 4 together, so we can have an aggressive treatment to combat this resistant strains of TB. So if the drug susceptibility test results indicate that bacteria are susceptible to all drugs, then ethambutol may be discontinued. Now, the continuation phase, then that will be 4 months, 2 to 3 times per week. Isoniazid and rifampin, INH and rifampin, will continue, and there's strategy or treatment strategy in the taking care of patients with TB called DOT, directly observed therapy, because we have seen that the non-compliance is a major factor in the multi-drug resistance and treatment failures. So that requires watching the patient swallowing the drugs, making sure that patient really actually and that patient is actually taking the drug. So we have to observe them. So the liver function test, LFTs, should be monitored, and also the because we said that the major side effect of isoniazid, rifampin, pyrazidamide is non-viral hepatitis. So this is rifampin rifidine, and rifampin, it's a broad spectrum uh, antibiotic or antibacterial used primarily for the TB. Rifampin also used for some meningitis, but it's non-monotherapy, but it's can be added also to other antibiotics in the treatment of patients with meningitis. But one of the significant side effects of the rifampin, that's that urine color changed just to the red-orange tinged urine or color. So the rifampin also we have another medication, which is the pyrazinamide, in which that about less than 50%, like 40% of patients with on this disease, on taking this drug, they will develop the polyarthralgia, which is like pain and the inflammation and pain in the joints during the initial phase of the treatment with this drug, with PCA. And that can easily be managed. So it's expected side effect. So it can be managed with the NSAIDs. Ethambutol. Ethambutol is one of the side effects of the ethambutol is the optic neuritis. Optic neuritis. And it's a dose-related adverse effect of the ethambutol. Patients receiving this drug should have e-color vision and visual acuity testing before therapy starts, before we begin the therapy with ethambutol, to do the color color vision and visual acuity. And then once we start patient on like a baseline, and then after patients receive the ethambutol, then we have periodically thereafter also the same test should be done or continue to be done, over like 3 or 6 months. So the drug therapy with latent TB infection, LTBI, usually treated with isoniazid for 6 to 9 months. An HIV patient should take isoniazid for at least 9 months. Because individuals, a person with a latent TB infection, they has fewer bacteria, less bacteria. So the treatment is much easier. Usually only one drug is needed with this latent TB infection. The 9-month regimen is more effective, but compliance issues may make the 6-month regimen preferable because of patients' non-compliance issue with these taking the drug every single day more than once. So an alternative for this strategy would be like a 4-month therapy with rifampin, may be indicated if the patient is resistant to the isoniazid. So that will be another alternative. If the patient is resistant to isoniazid, then the 4-month therapy with rifampin may be indicated. Now the vaccine, the BCG vaccine, which it's a vaccine to prevent the TB, and currently which is currently in use in many parts of the world. So in the United States, it's not recommended, and it can result in what we have seen, a positive PPD test reaction. So it's known for those who have been vaccinated with BCG as child within the first as a neonate or week 2 or within the 14 days of delivery, then the baby will receive the BCG, and that would result in a positive PPD test anytime the individual, as when they grow up, that will continue the case, and that we should recommend a chest X-ray instead, because it will be more confirmatory, or it will provide more details if there's an active TB or not. The nursing, we'll talk about more nursing, like implementation and the prevention, like health promotion, and more of these details will be also covered in Adult Health 2 course. So the nursing implementation, the ultimate goal in the US is the eradication of the TB, like selective screening, programs in high-risk groups to detect the TB, identify contacts of patients with TB. The person with a positive TB test or like PPD test should have an X-ray to assess for the presence of active TB disease. And this is what I just mentioned earlier about the screening and the positive PPD test, and we have to move on to that chest X-ray test. Now, it's also important that we have to place the patient suspected of having the TB on respiratory isolation, which is airborne precautions plus negative pressure room, in which that we will, use the N95 mask. So, and also we teach the patient hand washing after handling sputum soiled tissues. Prevention of TB. So we have what is called in ambulatory and home care. For example, like patients who have responded clinically are discharged home if their household contacts have already been exposed and the patient is not posing a risk to susceptible persons. Ensure that the patient can adhere to the treatment, teach symptoms of recurrence. For prevention, also we focus on the chemoprophylaxis. So give this chemoprophylaxis to people who are exposed to TB. 9 months of therapy is standard for the prevention of TB. And immunosuppressed patients are not candidates for this chemoprophylaxis. And we'll talk more about this chemoprophylaxis in Adult Health 2. This question asks about which patient or patients should be tested for latent TB. So we have only one scenario here. So the answer is B. The worker in the microbacteriology lab. Testing should be limited to people who are at risk of either having acquired TB recently or who might be progressing from latent to active TB. People who work in microbacteriology lab work with TB and they are at risk. So patients with some debilitating disease, such as like the disease that lead to debilitation and generalized weakness, very weak and weakness, like diabetes mellitus, they are at risk. The immigrants from countries where the TB is prevalent or will be also at risk. The employees of daycare centers and patients with cardiovascular disease are not at increased risk. So we can include, so we have included here two answers in which that we have B, which is the worker in the microbacterial lab, and E, which is an immigrant from country where the TB is prevalent. So the answer is B and E. In addition to patients with diabetes mellitus. So that will be the answer is B, D, and E. As has mentioned earlier about the patients with the debilitation or disease that leads to debilitation, general weakness, and severe fatigue, and generalized weakness that leads to a decrease or make the immune system kind of compromised. So patients, the answer is B, D, and E. Yeah, we can. So I think we are missing C here, which is the patients with cardiovascular disease, which will, which is not an answer in which that we said that the patients with cardiovascular disease they are not at increased risk for TB. So that will be again B, D, and E. Even though you can also include or add C, which is missing here from the question, which is a patient with cardiovascular disease, but that will not be included as an, in the answer. The second question or next question, a patient comes to the clinic for TB medication 2 weeks after beginning treatment with a full drug induction phase. So the patient's sputum culture remains positive and no drug resistance is noted. At this point, the nurse will expect the provider to. And the answer is to continue the full drug regimen and then recheck the sputum in 2 weeks. Now, in patients with positive pre-treatment, the treatment before pre-treatment sputum test results, the sputum should be evaluated every 2 to 4 weeks until the cultures are negative, and then the monthly or every month after that. So monthly thereafter. Again, in patients with positive pre-treatment sputum test results, sputum should be evaluated every 2 to 4 weeks until cultures are negative, and then monthly thereafter. Now, in the absence of a drug resistance, treatment with the same regimen should continue. The sputum cultures should become negative in over about 90% of patients in 3 or more months. The induction phase should last 2 months, so the patient should remain on a full drug regimen. It is not necessary to order the chest X-ray or radiograph or to add another drug at this stage of treatment. The patient is stable and has not developed symptoms that cause concern, so the patient does not need to be questioned about the adherence or compliance with the drug regimen. Next question. A patient has been taking the isoniazid for 4 months for latent TB infection, and the patient reports bilateral tingling and numbness of the hands and feet, as well as feeling clumsy. So what would you consider, or the nurse would expect that the provider to, and these are questions you're looking for the side effects and what are some of the medications that will cover the side effect or prevent it, or offset this side effect. So the answer is pyridoxine, which is vitamin B6. So patients sometimes develop from isoniazid as a side effect is the peripheral neuropathy. So the peripheral neuropathy will be characterized by paresthesia, numbness, tingling sensation, clumsiness, muscle aches, and if these symptoms occur, then that may be reversed by administering the pyridoxine, which is vitamin B6, but it's not necessary to discontinue the isoniazid. Lowering the isoniazid dose or adding rifampin is not indicated, or rechecking the test, the TST, and it's not indicated. So again, we will add once patient presented with these symptoms, which is a side effect or signs or manifestation of the side effect of the isoniazid, INH, then we will add this vitamin B6 to prevent or to reverse these symptoms, which is the manifestation of the peripheral neuropathy. Next question, which is a nurse is performing a physical assessment of a patient with TB who takes rifampin. What would be an expected finding? Which I have mentioned earlier about we anticipate that the rifampin will make the urine or the urine color to be red, orange, tinge a color, so that is expected. So this kind of urine tinged red orange is a normal finding associated with rifampin's adverse effects. Next question. E-home health nurse is caring for an older adult client who has active TB, and she lives at home with her husband who has tested negative for TB. She's prescribed the following medications: isoniazid 250 milligrams, rifampin 500 milligrams daily, the pyrazinamide PZA 750 milligrams, and ethambutol 1 gram daily. Which of the following statements indicates the patient's understanding of appropriate home care measures? As we select all that apply as multi-answer question, the first one is that I need to wash my hands each time I cough or sneeze. I will increase my intake of citrus fruits, red meat, and whole grains. And then the last one, I will remember to wear a mask when I'm in a public space. Now, the correct statements demonstrates understanding by the client on how to prevent the transmission of the infection and promote nutrition. All of the medications should be taken until the provider discontinues one, and the sputum collection should be continued to monitor the response of the disease to drug therapy. Second question, or next question, number 2, a client recently diagnosed with TB, prescribed medication ethambutol. Which of the following instructions should the nurse reinforce to the client? Clients taking ethambutol will need to watch for changes in vision due to the optic neuritis, such as blurred vision, altered color discrimination, and constriction of visual field. The clients receiving isoniazid, so ethambutol for this one would be the answer is C. Now, the the other, like we have also explained, would like to explain also the rationale for the other other distractors, A, B, and D, because the answer is C. Now, clients receiving isoniazid should take vitamin B6 every day and observe for signs of hepatotoxicity. Clients receiving rifampin should expect their urine to turn dark orange to brown. However, if the sclera turns yellow, this could indicate liver damage and should be reported to the provider because that's a sign of high bilirubin, hepatic dysfunction, hepatotoxicity. Sorry. The third question, a client with possible TB is admitted to the unit. The client complains of night sweats, coughing, and coughing up sputum that is spread with blood, which is hemoptysis, and patient also experiencing a weight loss. So the priority nursing action is to, and which is the precautions that's supposed to be initiated here is the airborne precautions. Now, patient exhibited with these symptoms automatically before even the confirmation of the TB diagnostic test become, like a sputum test or the chest X-ray and other tests. Before once patient we have to rule out TB. To rule out, in other words, it's suspected. Suspecting, when you anytime you suspect the TB infection, automatically put the patient on airborne precautions with negative pressure room. So the greatest risk is the spread of the infection to others. And based on the CDC, Centers for Disease Control and the Prevention guidelines, airborne precautions for the client should be initiated first. Obtaining the client's baseline height and weight will provide information to compare future data with obtaining the sputum specimen is necessary for diagnoses, and encouraging fluid intake will help maintain the hydration. These actions are all important, but are not the priority for this scenario. Fungal infections and the characteristics of the fungal infections, it's a single-celled or multicellular organism. The fungal infections it can be superficial or systemic. Now, the superficial so the fungal infection is called mycoses. Superficial mycoses infections, they may affect the scalp, the skin, nails, mucous membranes, and usually will be the superficial type. Will be usually treated with an effective treatment will be the topical agents. And then the deeper infections may require the oral antifungal therapy. And the patients at risk for the mycoses, we have two different forms. We have like oral candida, the thrush, and the vulvovaginal candidiasis or candida. And it's about like 75% of women experience at least once with this vulvovaginal candida or candidiasis. So the individuals or patients at risk for mycoses, in general, the human body quite resistant to the fungal infections. Most serious fungal infections will occur in patients with immunosuppression, or patients who are with immunosuppressed immune defenses. Patients like with HIV/AIDS, for example, patients on immunosuppressant therapy, patients at risk for fungal infections also will be may develop what is called the opportunistic infections, which will occur when the immune system is compromised. So the goal of the antifungal therapy is to remove or treat the body of the fungal infection while causing as few adverse effects as possible. The superficial infections, topical solutions are most commonly recommended. That's for topical. Now, the drugs for the superficial mycoses, which is usually caused by two groups of organisms, either the Candida species or the dermatophytic infections, like a ringworm, for example. Ringworm is the dermatophytic infections. So we have Candida species and we have the dermatophytic infections. Treatment for fungal infections. Four major groups to treat fungal infections. The main or the major one, which is the azole family, but we have four different groups. So the antifungal superficial, so antifungal drugs for superficial fungal infections, we have the nystatin, mycostatin. And there are other brand names for the nystatin. So the nystatin binds to the sterol in the fungal cell membrane, allowing leakage of intracellular contents. And that's how the drug will destroy this organism. So we have different forms of the this disease, which is again it's the dermatophytic infections like a ringworm. We have tinea pedis, which affects the feet, tinea corporis, which affects any part of the body. The groin would be is called the tinea corporis, and then tinea capitis, which is the scalp fungal infection, or fungal infection affects the scalp. The medications, as we said, nystatin or mycostatin, it's a polyene antibiotic. So that's the first group of antifungal drugs, which is the polyene, Polyene. That's the group, the first group of antifungal medications, polyene antibiotics or antifungal drugs. It's used only for candidiasis, for fungal infections. Drug of choice for intestinal candidiasis, intestinal candida. And also used for this nystatin also can be used for candidal infections, the skin, the esophagus, mouth, vaginal, and also can be administered orally or topically. This is nystatin, which is the mycostatin. Nystatin, nystop, cipolline drug, antifungal. The fungal infections, systemic infections now, not superficial, now the systemic infections, which affects the internal organs, typically lungs, brain, digestive organs, GI. They're less common infections than the superficial. We'll find always the prevalence will be more of severe, superficial infections, but not the systemic infections. Systemic infections are less common than the superficial ones. It can be fatal, and especially in particular would be in patients who are immunocompromised. So that will be treated with oral or parenteral, like IV medications. So the treatment can be difficult, in which that the fungal microorganism is unaffected by most antibiotics, it's not resistant to, it's resistant, or it's not responsive to conventional antibiotics. So the infections often resist this treatment or the antibiotic treatment. So the treatment may require prolonged therapy with drugs that frequently prove toxic. Now, opportunistic infections in which that patients like immunocompromised host, they have developed candidiasis or other types of infections like cryptococcosis and others. The non-opportunistic infections can occur in any host. So like histoplasmosis, the blastomycosis and others. So the treatment for the systemic fungal infections, the first very effective drug with lots of side effects is the amphotericin B, fungizone. Amphotericin B, fungizone. So mechanism of action, it binds to the ergosterol, the fungal cell membranes, and it will cause them to become permeable or leaky. That will lead to the destruction of the microorganism, the fungal organism. The adverse effect, it's severe, and to the point that that the drug, it's not preferably to be prescribed unless the patient had confirmed to have a systemic infection, and because it will lead, the side effects is fever, chills, vomiting, headache. At the beginning of the therapy, patient may develop phlebitis during the IV therapy, nephrotoxicity, toxic to the kidneys, electrolyte imbalances, very common, cardiac arrest, hypotension, dysrhythmias also. So these are very serious and life-threatening at some point, side effects from the use of this fungizone or the amphotericin B. So the amphotericin B is broad spectrum antifungal agent, and also it can be used against some of the protozoal microorganisms. It's highly toxic. Infusion reactions and renal damage occur in all patients to varying degrees. Must be given IV, no oral administration of fungizone. Sorry, there is a fungizone tablet, but we have one specific drug called the amphotericin B deoxycholate. That's different from this fungizone, but there is a amphotericin B, what's called the fungizone B 10 milligrams tablet. That's the only form of a fungizone tablet. But most of I would say, effective amphotericin B deoxycholate is IV. So it's a drug of choice for most systemic mycoses. And before the advent of this drug, before the amphotericin B, these systemic fungal infections were usually fatal, led to death. So the mortality rate before the advent of this drug was very high. So just to reiterate about the side effects or adverse effects of this drug, the infusion reactions, nephrotoxicity, hypokalemia, and hematologic effects. In which that the patients, when we say infusion reaction, like patients develop fever, chills, nausea, headache, and that's because of the release of the inflammatory cytokines. Symptoms will begin 1 to 3 hours after starting the infusion and may last for about like an hour after. Now, it's less intensive with lipid-based ampho-B formulas. The mild reactions. Now, what would we recommend that the pre-treatment options are very effective. Pre-treatments, because which is in which that we before we start the patients on this medication, we will give what is called the pre-treatment protocol. Includes the diphenhydramine, Benadryl, plus acetaminophen, Tylenol, and aspirin can help, but that may increase renal damage. But we recommend the diphenhydramine, Benadryl, and the acetaminophen, Tylenol as a pre-treatment option to prevent the infusion reaction. The nephrotoxicity, toxicity to the kidneys, the extent of the kidney damage related or can be, related to the total dose administered over the full course of treatment. More or longer treatment with the medication can lead to the more toxicity to the kidneys. So again, it's dose specific and also it's time specific. The extent of the kidney damage related to the total dose of administered of this drug over the full course of the treatment. If total dose over 4 grams, that may lead to residual impairment, most likely. Residual impairment. If total dose over 4 grams. The damage will be minimized by infusing the 1 liter of saline or normal saline on days of the treatment. So when we have the patient on the treatment, those days, try to put the patient on IV fluid that will reduce the risk of hepatonephrotoxicity. And also at the same time, we are going to avoid other nephrotoxic drug concurrently. Don't combine this drug, the fungizone, with the other nephrotoxic medication like aminoglycosides or cyclosporins, for example. NSAIDs should be avoided. And we will also monitor the patient's renal function test, kidney function test. For the hypokalemia, that may result from the damage to the kidneys, may also, patient may need the potassium supplement. And the last one, which is hematologic effect, can cause bone marrow suppression, anemia, and we can reduce the dosage to maybe like instead of 4 grams, we'll be like in 3.5 grams, and 3.5 milligrams per DL per dose. The azole antifungals, um, it's a broad spectrum antifungal drugs. Um, and it can be also drugs for both like systemic and superficial fungal infections. It has lower toxicity. It can be given orally, PO. Um, these are some of the azole antifungal drugs. And the drugs that may increase the these are the drugs that may increase the azole or the antifungal drug level in the plasma. So plasma drug level of the antifungal drug may these drugs may increase the plasma drug level of any of the antifungal drugs like azole antifungals. Plasma level may increase when it's concurrently given with these medications. The most commonly used, or which is prototype drug here also, is the diflucan, which is the fluconazole. Let's see, fungistatic. Its oral absorption is very good. IV and oral dosage the same. Um, we have also another drug is called ketoconazole. Ketoconazole. So the fluconazole, the flucan is well tolerated by most patients. Nausea, vomiting, diarrhea are reported at higher doses, but unlike the ketoconazole, so unlike the ketoconazole, the hepatotoxicity is rare with the fluconazole. So this is like one of the differences between ketoconazole and the fluconazole. Fluconazole is less hepatotoxic than the ketoconazole. So unlike ketoconazole, hepatotoxicity is rare with fluconazole. Although patients with hepatic impairment should be monitored carefully, even though it's less hepatotoxic, but still we have to monitor the patients with for the hepatic impairment. But this disease, in terms of side effects, the Stevens-Jones syndrome has been reported in patients with immunosuppression on the fluconazole. So again, the ketoconazole compared to fluconazole, these are some of the side effects, like GI, which can be reduced with food. If the drug is the ketoconazole is given with food. So ketoconazole, which is a nizoral, it's an azole group of antifungal agents that it has pretty much the same mechanism of action as like the fluconazole, which inhibits the ergosterol and the leak of the fungal microorganism, the and destruction of the microorganism. Now, it can be an alternative in terms of uses of this ketoconazole. It can be used as an alternative to the amphotericin B for systemic mycoses. And compare this to the amphotericin B, it can be less toxic and only somewhat less effective. So it's more useful in suppressing the chronic infections than in treating severe acute infections. The generally ketoconazole is well tolerated, but if there is adverse effects that will be a GI that can be reduced, as we said, if when we administer the drug with food, you can limit or reduce these side effects or the GI, side effects. The hepatotoxicity, it's very rare, but potentially fatal hepatic necrosis could result from this, the drug. The effect on the sex hormones, it can inhibit steroid synthesis in humans, and the other adverse effects like rash, itching, dizziness, fever, chills, constipation, or diarrhea, photophobia, headache. Um, so to enhance absorption of the ketoconazole, we can administer the Prilosec, the PPI, 2 hours after the Nizoral for better absorption, because the Prilosec will decrease gastric acidity. Protozoan infections, um, the malaria will be one of the infections. And it's most common protozoal disease, malaria. Second most fatal infectious disease in the world. And the protozoa that cause the malaria is the Plasmodium. And usually it's transmitted uh, by the female Anopheles mosquito. And this disease, malaria, requires multi-drug therapy due to the complicated life cycle of the parasite. So the treatment, the most effective or very common treatment for this disease, which is the chloroquine. This is the life cycle of the Plasmodium, how malaria infects a person has been exposed to the mosquito who's been infected with the malaria. Chloroquine actions and side effects. Um, Non-malarial protozoan infections. Metronidazole flagell. So this drug acts as anti-protozoal drug, and it's also has antibiotic activity against the anaerobic bacteria. So flagell metronidazole is the best antibiotic to treat patients with GI infections. So metronidazole was approved back in 1963. It's a bactericidal, and it has dual activity against both bacteria and a multicellular parasite. So it's a drug of choice for trichomoniases, giardiases, the amoebiases. It's anti-protozoal and drug or a drug for protozoal infections. The also very effective drug for H. pylori, even though we have a protocol now for the H. pylori treatment. The adverse effects of the metronidazole, the first one is the neurotoxicity. Like the patients may exhibit develop like seizures, confusion, hallucinations, and then the allergy and the super infections. So while on Flagyl, it's very important that we have, patients should avoid alcohol to prevent the disulfiram-like reaction. Helminth infections, which is infections caused by the parasite worms that cause significant disease in certain regions of the world. We have like roundworms, flukes, and the tapeworms. The like the roundworms is called the nematodes. The flukes are we have flukes that are called the trematodes, and we have tapeworms, which is the cetodes. But we'll just include here the roundworms and the tapeworms. So treatment or prototype drug for the anti-helminthic drugs are the Vermox, the brand name, and then the generic name is the mebendazole, and the mebendazole is a broad-spectrum anti-helminthic drug to treat a wide range of the helminth infections. This drug may interact with anti-epileptic medications or anti-epilepsy, anti-seizure drugs, AED drugs like carbamazepine, which is Tegretol. It may interact also with phenytoin dilantin, in which that will increase the metabolism of the mebendazole. And this concludes the lecture for this chapter.